Now I invite Dr. Harshul Tak for his talk about the newer generation optical biometers.
Thank you so much, Dr. Twinkle, for including me in your course. And we have been doing this course for many years now. And a warm good morning to all the delegates who are here in this early session. So I'll be speaking on advances in optical biometry. We all know that biometry is the practice of applying mathematics to biology. So broadly, biometry systems, we all know, are ultrasound based or optical biometry based. So A-scan ultrasound, it uses sound wave frequency of 10 megahertz and it has accuracy of 0.1 millimeters. The high frequency probe used in A-scan, it has minimal depth of penetration and which is excellent for resolution of smaller structure. That is, we use it for eye. But there are limitations of ultrasound A-scan. We all know that ultrasound, it depends on, it doesn't depend on patient fixation. It just measures the optical anatomical axial length of the eye from anterior to the posterior pole and not along the visual axis of the eye. So this is one limitation of A-scan. The second problem with ultrasound biometry is that it measures in front of the retina, that is from the internal limiting membrane. Whereas if you look at the optical biometry, these two problems are solved. That firstly, optical biometer, they measure the true optical axial length along visual axis of the eye. And secondly, it measures from the photoreceptors on the back of the retina where we get the true axial length of the eye. So if we have a look at the system on which the optical biometer work, basically they all are based on laser interferometry. So where there is one source of light which is split by a beam splitter, and there is a detector which measures the difference in the distances or path which the lights have traveled. So this is the Michelson interferometer on which all the biometers are based. So different OCTs, we have seen that we have evolved from the time domain OCT in which the constant phase difference waves were used to the spectral domain and the swept source based OCTs now which are used. So basically the basic difference in the spectral domain and swept source OCT is how the light is basically captured. So in spectral domain OCT, if you see, there is a photodetector at which the interference is done. Whereas in the swept source OCT, the light source which is used, which itself is a sweeping source, it has a variable wavelength. So that's the basic difference. So the first optical biometer which came in market was IOLMaster 500. And the IOLMaster 500 was based on the principle of partial coherence interferometry. It used a 780 nanometer multimodal luminescent diode. But the limitation here was that this IOLMaster 500 only measured axial length truly optically. All other parameters which we need for the newer generation formulas like the antechamber depth, lens thickness, ACD, they are not measured by IOLMaster 500. Then came LensStar 900, which was based on optical low coherence reflectometry, and it used 820 nanometer superluminescent diode. So it truly measured corneal thickness, ACD, lens thickness, and axial length. So this is the basic two difference in the IOLMaster 500, which use PCI, and the OLCR by LensStar. So basically the light source used in the IOLMaster 500 is the MMLD. As you can see, it's a multimodal luminescent diode. So it creates a lot of secondary maximal waves. That's why it cannot measure through ACD, lens thickness and corneal thickness. Whereas in OLCR, it uses SLD, so it gives a continuous wave. And secondly, the setup which is used of the both the systems is different. PCI use dual beam setup, whereas OLCR uses a rotating glass cube system. So then came ALScan, which was again based on partial coherence interferometry. It used 830 nanometer SLD to measure axial length. Then came Aladdin, which is based on OLCI, that is optical low coherence interferometry. So limitations still ILMaster 500 and OLCR, Lenstar and all these instruments were not in measuring axial length, but was in the penetration in the denser cataracts, because they were not able to penetrate through the dense subcapsular cataract and denser cataract, and they only measured anterior cornea. So then came the instruments which are now based on the swept source OCT. The advantage, as I said, is they can penetrate better through the denser cataracts, and they also measure the posterior cornea, so that gives total keratometry, as Dr. Tinkle also mentioned. So ILMaster 700 is based on swept source OCT, and it has a scanning rate of 2000 scan per second, and it gives corneal thickness, antichamber depth, lens thickness, axial length values. So it measures keratometry in 3 zones, 1.5, 2.5 and 3.2 millimeters, as you can see here. So these are the 2000 scans which are taken per second in 6 quadrant, 0, 30, 60, 90, 120 and 150 degree. And you can actually see whether the fixation is proper or not, patient fixation. As you can see on the left side, we see a good foveal pit. It means it's a good fixation. So, as Dr. Tinkle also mentioned, it uses 3-zone keratometry, and 6 spots are used at 1.5, 2.5 and 3.5 millimeters. And it has incorporated Barrett TK formulas, like Barrett TK Universal 2 for normalized, Barrett TK toric, and Barrett True K with TK for post-refractive surgery eyes. It also gives angle kappa, which is the distance between visual axis and pupillary axis. Then another biometer which is there in market is OA2000 from Tomy. It's also based on swept source OCT. I'm personally using this for last 8 years. It has a scanning rate of 1250 scan per second and uses wavelength of 1060 to measure. It gives all the readings, axial length, ACD, CCT and lens thickness. It also has a Placido disc which has each ring has a 256 points which are projected on the central 5.5 millimeter of the cornea, and we can obtain K values at different diameters, 2, 2.5 and 3 millimeter. Then we have Argos, which is again based on swept source OCT. Then Anterion we have recently from Heidelberg, which uses wavelength of 1300 nanometers. So to conclude, swept source based OCDs, they provide repeatable and reproducible measurement in different ocular parameters, and they are more effective at obtaining measurements in eyes with denser cataracts. And they also provide good accuracy in alpha calculation. And I think now optical biometry is the gold standard for doing all our IL calculations. Thank you very much for giving this